Hello, thanks to be with us, Josep. We will start maybe, before presenting the statement, with a little introduction. And the first point, which is not that, which is really necessary, is trying to view exactly what is the scope of poor prognostic cancer, as you may have defined it in the group, because there might be a lot of definitions.
Well, thank you. First of all, I would like to thank the French presidency and the INCA for inviting me and for this initiative to organize this meeting that it's very relevant and very important. So, poor prognosis cancers could be defined in several ways, but I think all of us agreed on the definition of one-third lower on the definition, focusing on survival in less than 33%, 5-year survival. So all the cancers that fulfill this condition, I think, could be defined as a poor prognosis. I must say that it's the same definition, a similar definition than we use in the IPAC with neglected cancers, that maybe it's a word that give focus to the lack of recognition of these cancers. And I must say that it's, considering this definition, 1 out of 4 cancers in Europe, diagnosed cancers in Europe, are included in this group. So it's a large amount.
Still a main issue. It was a group, as much as I could hear, where there were a lot of accurate and intense discussion, very precise discussion. Yet it was maybe the group where they had this, I don't know how to say, a certain sense of feeling of fatalism, like, let's try, let's go. It won't work. We won't have the support. We won't go to the end of it. Do you agree on that? How can you explain it? And what are for you the main challenge to come on this poor prognosis cancer issue?
Well, I think any cancer poses a challenge to any clinician and the patient and the family and the health system, but poor prognosis cancers pose specific challenges due to the lack of survival, and that could also provoke this kind of fatalism around these cancers. But the group, I think, agrees on the fact that we can do something, and we can act now, trying to apply what we know that could be effective, and to expand in the health systems in order to offer the best we can offer to our patients, and obviously support research to change. But I think the message is we can do something now.
Yeah, that's the motto out of the assessment is yes, it's difficult, but yes, we can do something for real. With the 3 different statements, and we're going to discover them. The first of them, is this the first? Yeah, yes, this is the first one. You can read it. I'm not going to read the whole of it. Actually, make research the priority to radically switch approaches to poor prognostic cancer. Call this high-risk eigen proposal at European level. This high-risk eigen program, if I can say, is here to boost research against this cancer. What exactly do you call high-risk eigen? The name is really nice, but what's behind the name? And how could it be a game changer, or at least a game booster on research on this poor prognostic cancer?
Well, I must say that there was a significant discussion about the concept of risk, because it could be easily misunderstood in terms of patients, from the patient's perspective. I think that the meaning, it's clear that we need disruptive approaches to this kind of research. So we need to support innovative projects in this area. So the situation so far and the research so far...
What is called innovative project? Because, I mean, every research project is innovative by itself.
Well, in some cases, I must say that several research projects try just to confirm what we know or to expand slightly. But I think we need projects that could change the game and offers new approaches to different perspectives to treatment, to basic science, to epidemiology, to the risk factors definition and things like that. So I think we need to support really original ideas to offer different perspectives that could be different from what we know and the classical approaches to this research. I think the focus is in innovation, but innovation changing the game and the field in order to see if we can offer better solutions.
does it mean, because it's having like new blue sky research thing, it's a bit of this actually, is something interesting, but I mean there's a call for research programs, and in the calls there's criteria, and the criteria says need to have this proof of concept, and if you don't have it, just it's not for, the room is not for you. Does it mean that you have to change the selection of the project, the vision, the definition of proof of concept as the entrance path for getting the support on the programs?
Well, yeah, I think probably the definition of the calls should slightly change. I think also we should make clear that we prioritize this kind of projects, focus on these poor prognosis cancers, which is, I think, something controversial, but for us it's important to really highlight the relevance of focusing research on these cancers, because if not, due to the fatalism, due to the fact that these cancers seems without any kind of, let's say, practical solution, even researchers are not interested in applying for this kind of cancer. So I think we should make clear that we give importance and relevance to do research in this area from, let's say, innovative perspective.
It's not a switch, it's a complementary approach from the traditional approach, actually. Let's go to the second statement, and the second statement is about I would say the data sharing, if I'm correct. It's important. It's important to provide a framework and tools to enable the engagement of health professionals and researchers to share the data in advance of project. We talked about this yesterday, in order to better understand barriers and benefits from each other's progresses. This is very important, but why is it so important on this field of cancer, and how, I would say, not to make it just a declaration of intent, one more on data sharing, because we said yesterday everyone wants to share, but at the end no one is really able to share, because there's always so much problems when it comes to really go to sharing.
Yeah, well, this is one of the things. Certainly, we discussed yesterday two ways of sharing data. I think we need to share data because we need to monitor data about outcomes and the process of care, and to learn from each other. So I think this is, but this needs frameworks to make the definition of the variables standard, and to structure the data in order to be able to share this data. Because I think one of our main goals is precisely to develop what we can call a learning healthcare system. So a system that learns from the experience of the day-to-day work with patients. This is one of the ways that we can do, and I think this is particularly important in this kind of tumors, because there are good experiences across Europe that should be shared, and should be shared with data, not only with the concept, with the idea, I think with real data that could monitorize and assess the good outcomes. And I think also, and it was I think one of the points yesterday, we should share data as early as possible in the beginning of the project, not just to wait at the end. So,
meaning as a condition for support in the program?
Early in the implementation of the project. I think because it's also relevant to learn about the barriers and to learn about the difficulties based at that usually comes out at the beginning of the project.
It means that the data of one research could be freely used by other researchers?
Yeah, I think data should be shared openly, obviously following the privacy regulations and all the regulations, but I think there are ways to share, and we have developed fair programs and fair approaches to share this data, and we should support, especially in this area of poor prognosis cancer. Yeah.
It can be, even though a kind of a pioneer field to create this disposal of sharing of data. Next statement, the third one, is more focused on the model of care of this poor prognosis cancer in order to improve the diagnostic, the access to treatment, the quality of life of the patients with it, ensure the best available care is provided by increasing quality and speed of delivery for patient as an individual and for patient population as a whole. It's a large scope, actually. can have a lot of things inside of this. It could be early detection, could be treatment, could be quality of life, and should be the whole of it, actually. What is the main issue the group wanted to address on these different aspects in this statement?
I think it's important to realize that we need to focus on two levels of care. So one is with the individual patient and the individual clinician, and here from this perspective, I think multidisciplinary care, development of expertise, concentrate expertise, and offer early access to this expertise for offer the best treatment that we can offer. I think, but this also has a strong implication in the organization of health services and in the healthcare policy. I mean, when we are talking about, for instance, developing highly expert groups, multidisciplinary teams in referral centers, we are talking about health policy. And I think it's important because this is also aligned with Europe's Beating Cancer Plan and many of the cancer plans in Europe, that they are talking about offering comprehensive cancer care to the patients in comprehensive cancer centers. I think this is important. And this has been shown to offer better outcomes and better quality of life to the patients. I think this is important because this could be implemented now. So this is something that has to do with policy, and not only with, let's say, the individual treatment of one patient. So it has to do with how do we organize the timely access to this treatment.
So it will be also a way to look at the implementation of these comprehensive centers and the way they can work in the different countries also, and also to reduce inequalities in the countries, which is one of the objective of the network of comprehensive centers.
And this offers two additional advantages. These are better places to carry out research projects. And the second one is that you can easily monitor the outcomes, so certifying that the quality of care is as good as it could be. And also, it should be complemented with a focus on quality of life and palliative care if required.
Necessary, because usually the patients are facing problems to access to treatment, access to diagnostic, and also social difficulties that can really accumulate the problems. Next question is a question I will have to every voice speaker. What shall be for you the next step to come? I mean, you know, the clock is ongoing. What's next?
Well, then the next things, I think it's important to raise awareness of the things that we can do and the problems associated with this kind of cancers. I think this is important because if not, we are not talking. So sometimes when you read news on the newspapers about cancer, you think that this is almost solved, and it's not. So we need to do a lot of research. So raise awareness, for me, it's important. The second thing, obviously, it's a focus on research, because it's important. That will eventually improve the situation, but also that we need to do something now. So we cannot say, well, you know, research and we need more research, which is something that we agree on. But on this, I think there are many things or several things that could be done in terms of organization of healthcare, of access, of sharing good clinical guidelines and monitoring the implementation of guidelines, things like this, assessing the policy initiatives around Europe. I think things like this could be done immediately on the short term.
Yeah, as I said in the beginning, there was maybe sometimes a kind of sense of fatalism in the group, but also impatience. I mean, they want things to be done really happening. We have a few minutes left because it's a 20-minute time for each. Maybe we can use that to take comments on these statements from the audience. Also, the connected audience. It can be in English, can be in French aussi. Ça peut être en français aussi, hein, les commentaires. So I don't know if that doesn't have to be a real question to Josep. Can be, but Josep is speaking on his name. He can be speaking on the group name. But if you have some comments or complementary point you want to address on these statements, or on the statements that are not there but could be, please don't hesitate. Raise your hand, and a mic will come to you. And also on the internet, of course. Thank you very much. Normalement, ça marche. Voilà.
Thank you very much for this.
Ah bah ça, normalement, la première fois ça marche pas, la deuxième fois ça marche. Et là, est-ce qu'on peut, il y a un autre micro qui peut venir pour Monsieur Blé?
I can scream otherwise.
No, this is not an option. Not in that room. This is not a room to
No, I think it's working.
Oh,
yes. Yes, on top of innovation and treatment, on local treatment and systemic treatment, which we all acknowledge is crucial, I think that there is a wide area where we could increase things simply by applying at the best level the clinical practice guideline and the best practices. When we look at that on some specific tumor types, and we are here with the RNs trying to show that, we observe increase in long-term outcome and survival, which is of a magnitude of 10 to 15% by itself, which of course makes a big difference. My question is, how can we ensure that at the European level? And I think to measure that first, and probably registries are going to be crucial, and I would like to have your opinion on that.
Yeah, I think there is a long way of things to do in this way. I think the first, obviously, is sharing data, but also for me, it's also using data to implement measures. So not just sharing data for publishing, if not to implement. And I think from the policymaking perspective, our policymakers should learn that there are things that could be done, but changing the way of organizing the healthcare in a way. So I think that this is the first thing. The second thing is monitoring the implementation of clinical guidelines. So clinical guidelines are not only to be published, are to be implemented, and we need to monitor the implementation. At this calls for an action at meso level, so at the managers of the hospitals, the managers of the cancer centers, and things like that. And this should be supported by cancer plans. I think the European Beating Cancer Plan, it's really an enormous step forward, but I think we need to also to build cancer plans at national level, to focus on this way, on this approach to change the way that we deliver the care. For instance, in my country, we need to expand the concentration of care for some specific procedures, for instance, surgical procedures. And we are doing, but it's not an easy task to do. But I think this is important, this European perspective, to set, let's say, a bidirectional approach from the country to Europe and from Europe to the country. I think this is very important, and also to learn from the others' experience. So I think this is important.
Is it in complement to what Jean-Yves Blé said, on this last proposal, might there be also something about the clinical indications on this poor prognostic cancer? Because usually, as much as I could see, some countries have their own clinical specifications, guidelines, and there's international guidelines, there might be European guidelines, and so they spend time translating, and then at the end, who are the best ones and who are the good ones. Might there be also a kind of harmonizations of the guidelines? On this specific cancer, it might be an issue.
Yeah, we need to avoid duplications of guidelines, simply repeating guidelines, because of you need to write your own guideline. I think to learn from each other could be useful, and there are very excellent guidelines developed at European level. So I think what we need is to apply. So the challenge is not to write a new guideline. So the challenge is to apply. And I think this should be the focus for doing this.
One question from the internet is, is there a specific plan for pediatric cancer with poor prognosis? Can answer that question, and also the fact that there might be a link in between your two actions. We're going to see it.
Yeah, I think, well, the pediatric cancer will be another restitution, no? But yeah, I think we need to learn from pediatric cancer, because pediatric cancer 30 years ago, 40 years ago was more or less in the same situation that we are now in poor prognosis cancers.
Yes, there's here, yes. Bonjour.
Thank you, Ruth Ladenstein. I'm heading the EAN PETCAN as a coordinator. And I just want to build on what Jean-Yves just said, and addressing also your question on the guidelines. Just pinpointing that I think working together towards common standards is an absolutely crucial key, and I'm quite proud that the pediatric community over the last 12 to 18 months, the European clinical trial group's main themes have established common agreement on frontline setting guidance. So we are not talking about the diversity one against the other, it's a common voice of guidance. And we will measure this with a registry, very slim, but much larger than an epidemiological registry currently is. And so implementation is now the next step, yeah, how to make it a reality. And I think the more we bring it to the national level with all the measures into health systems to appreciate such a common voice of experts towards a better implementation, I think this is absolutely key. Yeah, so thank you, very supportive, but I think we need to create this common feeling and common voice across unify the community, actually.
There was another comment there, yes.
Oui, Yann Gaudouel. Je voudrais faire un commentaire un peu appuyé sur la... Excusez-moi, je le fais en français pour être bien perçu du point de vue de la dire. Je voudrais faire un commentaire sur la première proposition, à savoir les recherches fondamentales disruptives. Pour avoir fait 40 ans de carrière dans les recherches disruptives, je peux vous dire que c'est une prise de risque énorme. Donc le haut risque, haut gain que vous mettez pour définir cette stratégie, elle n'est pas perçue comme telle par les chercheurs en général, car vous savez très bien que ce n'est pas le risque qui est valorisé pour la recherche, fondamentale notamment, c'est la quantité, à défaut de la qualité, la quantité de résultats publiés. Donc comment allez-vous mettre en place au niveau européen, je ne parle pas uniquement qu'au niveau français, une stratégie intéressante pour motiver les nouvelles générations de chercheurs à la fois à prendre des risques? Comment allez-vous mettre en place des comités ayant l'expertise pour évaluer les recherches à haut risque? Ce n'est pas si évident que ça. Et enfin, comment finalement allez-vous mettre en musique ceci au niveau européen pour que c'est un sens et que ça ne soit pas uniquement une simple déclaration d'intention?
Josep, we don't have time anymore. We're really out of time. But these are stuff to think about in the group. This is a inspiration for the group. Okay. Thanks a lot, Josep, for your comments and your presentation. Thank you.